Connecticut. This is Grant Ritter, Chair. To be again the meeting, let me remind everybody to please identify themselves before they speak, at least the first few times, so we can put a voice with a name. And to begin the meeting, Marcin, could we have an attendance? Can we take a roll call?
Yes, Mr. Chair, but before we do that, I just want to note that this meeting is being recorded for minute-taking purposes, as well as for posting of the proceedings on the agency's website. This meeting is also being live streamed on the AHCT website. Roll call for attendance. Grant Ritter, Chair.
Yes, present.
Sean King.
Here.
Mark Schaefer. Matthew Brockman. Manisha Tutani. June Goin.
I'm on.
Thank you. Brendan Riff. And Paul Lombardo, subject matter expert. Thank you, Mr. Lombardo. We do have a quorum, Mr. Chair.
Okay, thank you. Next, public comment. Do we have any public comment?
And no, Mr. Chair, we did not receive any public comments.
Okay. Next, the minutes. Could I have a motion to approve the minutes from the January 15th meeting? From someone that was there.
So moved. This is Sean.
Thank you, Sean. Second?
Second, this is two.
Good. Okay, 2 seconds. So were there any edits, comments, revisions? Does anybody have any changes to the minutes that they'd like to ask about? Well, if not, could we have a vote to accept the minutes, to approve the minutes?
Grant Ritter?
Yes.
Sean King?
Yes.
Mark Schaefer?
Yes.
Matthew Brockman? June Goin?
Yeah.
Brendan Riff?
Yes.
And Manisha Tutani. Thank you.
Great. Minutes are approved. I'd like to turn the meeting over now to Kelly to do a follow-up on our mission, vision, and values.
Good afternoon. We have some minimal follow-up. Julie from Wakely will be presenting before getting into the standard plan options. Some follow-up that was requested from our previous meeting. So with that said, I'm just going to pass it over to Julie to start the presentation.
Okay. Julie?
Yeah. Thank you, Kelly, and I apologize. I'm going to be off camera due to some connection challenges. So let's go ahead and advance. We have some updated news. We do have a final regulatory notice of benefit and payment parameters that occurred since our last meeting. So we don't have any outstanding regulations except for the HSA rules, which will be coming later in May, as we discussed. And so on the next slide, where you see some information about the out-of-pocket limits, et cetera, those are all finalized with that, as well as other regulatory requirements in the NBPP, except for the HSA, as noted in the bottom box. On the next slide, we do have some updated information. These are the analysis of the current 2025 plans under the 2026 actuarial value calculator. We do have confirmation on the 87% AV, as well as the 94% cost sharing reduction plan, that those two plans will also require modifications based on the feedback of one issuer. And so we have received feedback from most plans about the information in here that I'm going to be presenting today, but we haven't heard from all issuers. Just the timing was very tight, et cetera. So some of the presentation will be based on that. But from our meeting last time, one of the questions was, a concern was raised about changing in the copays. And so, what I took away from that was to go back and look at some of the literature and some of the studies that have been done about the impact of changing the cost sharing components, specifically copays for office visits. What I found is, most analysis has been completed on drug copays, and most of it, the focus has always been on Medicaid and the Medicare environment. However, there is, some things that we can carry over for review to how it might impact the individual commercial market. One of the things that we found is that, a change in copays, of 5 to 10% could reduce utilization by $5 to $10, could reduce utilization by maybe 20%. But that's often an example of going from $0 to a small copay of, for example, $5. But in reviewing the studies, what I found is that, there's just not much consensus on what is the outcome or what is the reason for the reduction in utilization. Is this a reduction eliminating waste in the system? Did the copay drive utilization to more expensive care? And then, one of the challenges that is found with evaluating VBID programs is this, would the lower copays have drove better health outcomes? And so one of the things I found is in the Kaiser Family Foundation analysis, in looking at CHIP and some other programs, that, for those that have non-chronic conditions, the utilization shift from an increase in copay was the greatest. And so for those who had chronic conditions, there might be initial shock from the change in the cost sharing, but that normally those changes in copay would normalize and they would return back to their previous utilization patterns and behaviors. There was one ACA study that was done in Mississippi, and looking at the impact, they added one additional non-preventive office visit, so one free additional non-preventive visit to their program. And what they found is that there wasn't a change or a shift or decrease in the utilization of emergency room utilization or urgent care. So, basically the consensus on that study or analysis was that there are other drivers in the system beyond just cost sharing that's driving the utilization of those higher means of care. And so I don't know if anybody has any questions. I'd like to stop here and see what feedback there might be.
Sean has his hand up, and I'll follow Sean if you don't mind.
Yeah, I'll go first, and Mark may probably articulate my questions even better than I'm trying to. So, it sounds like as you mentioned, no real consensus on impacts at various, well, much less at various income levels, but even just overall. Because one of the things that we're trying to figure out is, when we're deciding between raising co-payments versus raising deductibles, how are those choices likely to impact utilization for better or for worse? But what I'm getting is that the research isn't clear, but if I'm reading between the lines, it's kind of leaning a little bit towards these small incremental increases in a copayment for drugs or a copayment for an office visit is not likely to deter members, a large number of members from getting the drugs or the care that they need. So maybe I'm not reading that right or not hearing that right, but that's kind of the gist that I'm getting. Is that fair to say?
Yep. Yes, that is, fair to
Okay.
say, is that, for those, that's had chronic conditions or care, that their utilization patterns didn't change very much. It was where, someone that didn't have chronic conditions might have thought twice about going to see the doctor. So maybe they're like, oh, it's an ear infection or it's a sore throat, something like that. I'm just characterizing that. There's, as you say, it's like based on what the study said, is that there is either a blip in utilization or there is a reduction in utilization. But the driver of that, there's no consensus. Is it reducing waste? Is it really removing or putting a barrier to care that would impact outcomes? But just looking at the VBID programs that have been out there and the plans that have initiated VBID and then pulled back on them, it seems that they either didn't find the health outcomes they had so hoped to see by reducing cost sharing, and so that's why they went back to a standardized cost sharing program. But I would agree at a high level with your consensus. And the challenge is because of the structure of the actuarial value calculator and the marital tiering ranges that we need to comply with, they are forcing a change in cost sharing. The question is just what mechanism, unfortunately, that we have to use as a lever to achieve that goal.
Thank you.
So I don't know if you can see that I'm raising my hand, but I'm raising my hand, so I'll just sort of jump in. So first of all, I'm astonished that there's so little research on this, given how much is said publicly about the impact of out-of-pocket costs on appropriate healthcare use. And I don't think VBID studies are the typical, wouldn't be where I would look, since cost sharing is not necessarily exclusively in the province of VBID. It's a feature of health insurance designed today sort of universally. I know that Data Haven just completed its latest survey about whether folks have not accessed services. I think medical services, it might have included drugs, but I think there are surveys out there that I recall, and I'm going to look up the Data Haven report, that basically asks the question, did you not seek care or get your drugs, prescribed drugs, because of cost considerations? And I'm certain that I've seen survey data that establishes cost as a barrier. And so I think we can't conclude that more cost is not a barrier. And it says right here, drug utilization appears to be the most sensitive, so higher drug copays are likely to impact. That suggests to me that it's likely to impact drug utilization. We don't have much of a choice about whether to make adjustments to the plan design and the sort of cost sharing strategy. We do have the opportunity to, on a going forward basis, to try to be evidence informed. I recall from the last meeting, I have a recollection of having made a lot of adjustments over the last number of years that they've come up, and I would be interested, and not as a to-do for before we approve anything, but it would be interesting to see the history going back 5 years of what plan modifications the committee has approved, sort of what's our what has been our strategy and where have we held the line and where have we chosen to impose more costs. The comment that I have about is one about applying improvement science to the way this committee operates, which is to consider every recommendation we make that gets implemented to be essentially a natural experiment. And it gives us the opportunity to look on a year-over-year basis at how, if at all, utilization patterns change as a function of the imposition of additional cost sharing in its various forms, and whether there's a countervailing increase in ED use and so forth. Is the data? It's my understanding that the exchange plan data does get submitted in its entirety to the all payer claims database.
That's correct, Mark.
And have
And
we?
it should be.
And has Access Health Connecticut ever solicited that data in order to do a study of the impact of changes in cost sharing?
We have asked for some data from the APCD, not specific to the point you're making, Mark, but about a request from a few years back looking at the utilization of the preventative services through the plans. We've just been having a lot of challenges with the APCD, quite frankly, about getting the correct data. We've gotten, and Kelly can speak to this more, we've gotten data from them more than once, and it's not exchange data, or only a fraction of it is exchange data, and they're submitting. So there may be some issue on their end with the data they're pulling, or with the way carriers are coding data when it gets submitted. But we've been trying to work through that with them so that we can just look at an actual de-identified data set of just exchange plan data.
So we're just doing our first run around the track with a full download of all APCD data. And I might circle back with Kelly to learn a little bit about your experience in trying to use that data, since we might be able to avoid some pitfalls in that. But we did wonder about the commercial coding. So my point is, if that's a soluble, I guess the question is, and again, not for decision making now, but if Access Health Connecticut could retain a research consultant to undertake an evaluation of the impact of these, which is on a big enough population that you should see the impacts, and you could, and you have, at least in aggregate, when you combine all the payers. And I think it would frankly make a contribution to the national literature, in addition to allowing us to not just guess, because that seems like what happens or has happened in the couple of years that I've been on the committee.
Well, this is, so we're going to go on and look at the goal plans, or do you want to address the study? I think reviewing the experience can be done. It's a little bit challenging as opposed to looking at Medicaid and Medicare, just because of the choice that consumers have in the marketplace and tracking them through the system as they make changes in either non-standard plan designs or moving among metals.
Right. That is something, and I think we have looked at that, Mark, just generally just about consumer behavior, about where they go year over year, whether they stay in the same tier, whether they stay with the same carrier, and other than the silver, whether they move, between standard and non-standard plans. So there is definitely movement. So it's a little harder to see, year over year, because it may not be the same consumer that was in that plan last year.
Yeah, I understand. There are sort of valid comparisons that can be made, even if it's not the same consumer year over year, in terms of the population that is subscribed to a plan in a given year. And, you might even be able to apply um, uh, adjustments to the sample to basically have comparisons between the two, between years in a way that adjusts for changes in the characteristics of the patients who choose one or another. My only point is that, we've been a leader on the exchange since we rolled it out. These are critically important decisions we're making, and we're making them in the absence of much evidence. And there is, I think there is expertise out there that could be tapped that we were willing to fund it, that could make best use of the data, even despite those limitations. And so I would hope we could take that up as consider whether that could become a committee recommendation, and two, whether that would be something that's within the realm of the possible.
So, hey, Mark, let us take down the advice and get back to you. And also, we want to, we have a strategy committee, and see if this is where it belongs. But there's some limitations, obviously, I'm sure you're aware, because of the federal rules and the AV calculator. What we cannot do is limited because of that. So let us look at if it's feasible to do a study, as you suggested, and we will discuss it at the board level. I mean, the finance committee, and take it from there. So we'll come back to this committee.
That sounds great.
I don't know if it's going to be anytime soon, but we will get back to you rather sooner than later.
Appreciate it.
All right.
Okay.
Well, so we'll go ahead and talk about the gold plan options. These were presented at the last meeting, and there's no changes into for this time period. We still do not have full clarity as to the passage of these plans and the plan options under mental health parity. We've proposed a change to bring this into compliance, shifting the cost sharing on certain key mental health services within regulations. But until we get confirmation from the other issuers as to whether or not this will work, it didn't seem appropriate to present it at this time. So we'll go ahead and just focus on the changes as proposed from the cost sharing metrics. So as noted previously, option 1 focuses on copay changes more so than just looking at the deductible and MOOP, which is option 2. And while option 3 is more of a mix of those options. Since these plans are not finalized yet because of the outstanding mental health parity issues, why don't we go ahead and advance to the silver options?
Okay. I have a question here, Julia. Is the $45 primary care approved by the state? That we were always running earlier in our careers. We were running into a maximum copay, but I don't know whether the state has increased it over the years or what. But you are moving up the primary care to $45. I wonder if that was acceptable.
I'm not. Oh, go ahead, Susan.
I think, and I know Paul may be busy right at this moment, but my understanding is that there is not a copay max that we have to be concerned with in this area right now. They did have early on in the early years, there were copay max from the state, but I think a lot of that has changed over the years. Grant.
Okay, thank you.
Thank you.
That's correct. I think that the only existing statutory limits are on therapy services for physical, speech, and occupation, as well as imaging services.
Mm-hmm. Mm-hmm.
So again, similar to what was done in the gold, we presented 3 different options, focusing option 1 on a copay driven solution to bringing the plans into compliance. And so option 1 raises the primary care copay by $5 from $40 to $45, as well as increases some of the drug copays by $5 as well for the generic preferred brand and non-preferred brand. Option 2 looked strictly at initially a deductible maximum or out-of-pocket solution. But because of the constraints of the actuarial value calculator, it necessitated additional increases to the primary care copay as well as to the generic copay from $10 to $15. Option 3 attempted to increase those deductibles at a smaller amount, increasing from $5,000 to $6,250 instead of the $7,500 in option 2, as well as a smaller increase in the maximum out of pocket, going to only $9,500 instead of $9,750. And these changes still fell within the range. You can see from the very bottom row that you know, instead of being at, you know, 70.1 and 70.5, the option 3 is a little bit higher at 70.4 and 75.8. So the differential, although, you know, in the plan designs, is that the differential in the cost sharing between the enrollees and the issuers will be fleshed out through differences in the premiums between these 2 plan options. These have all passed mental health parity testing as well as the actuarial value. So it would be appropriate to for people to ask to narrow down the options per se. I see there's a question, Sean.
Yeah, actually, just a quick comment. I mean, I just thinking out loud here. I'm not sure why we would choose option 2 over option 3 under any circumstances, but maybe you can elaborate on some reasons why we would. And then my question is, did we explore ways that for the drug cost shares, possibly adjusting some of like the preferred brand or specialty cost shares as opposed to the generic to hit the AV values that we're looking for?
We looked at several different scenarios. We were trying to make small incremental changes, and so just because of the weights of the different service categories, that was kind of how we made those changes. As proposed, to not make a change to the generic would require probably either much greater changes in the preferred and non-preferred brand, and that is something that we can look into if keeping that generic copay low is desired. It just might mean that we may have to look at some other service category changes as well. So I would throw that as a concern.
Yeah, I'm just curious. I'm by no means an actuary or mathematician, but just kind of looking, just comparing these columns a little bit. I don't know. I'm just kind of wondering if we can, if there's some further balance we can find where the increase in, if we take option 3, for example, and not increase the deductible and out-of-pocket max so much, but maybe bump the preferred brand up to 50, for example. Just wondering how many of those kind of alternative options have been explored.
We've looked at a couple different options. The challenge is that each of the issuers needs to do their testing, and so what we try to do is do a best estimate of what will be coming in compliance. So we're not having the issuers testing 80 different plans, and we also ask for their feedback for changes or proposed plans. But that is something that we can look at. So let me just kind of try to recap your feedback. Is to hold the generic copay to 10, try to increase the preferred brand copay to 50, and then see what changes are necessary to the deductible and MOOP to bring it into compliance.
Yeah, myself personally, I just don't love such huge increases in the deductibles, especially without good solid evidence that as we were talking about earlier, good solid evidence of which of these changes is gonna impact, how price sensitive people are to the different types of changes, what the impacts are going to be on utilization. Because of my own personal feeling, still evolving depending on how much information and studies and research we can gather, which seems to be limited at this time. But my own personal feeling is that the smaller incremental changes to co-payments are potentially a better idea than foisting a bunch of larger costs on the people who end up being the most sick, and utilizing the most services over the course of the year.
I tend to agree with Sean, and I think that this is Mark Schaefer. And I think that the effect of a significant illness that's, that if I haven't read the research on the accumulation of medical debt, but I assume it's driven less by copay type cost share and more by that significant event that results in an all at once out of pocket obligation in excess of X. So I am inclined to sort of agree with Sean that it would be good to have another model. I do find option 2 and 3 puzzling, as Sean notes, because it's like we would just be increasing the deductibles for the hell of it. I think a different option 2 that maybe takes the 15, 50, and 75 on the drug cost share, keeps the primary care at 45. Can we make it a relatively nominal bump up in the medical deductible and out-of-pocket maximum?
So I'm sorry, what would you want the drug numbers to be? What was your recommendation?
Sean, I don't know what you think, but I think 15, 50, and 75. So not going all the way to 20 for the generic.
Okay, 15, 50, and 75. Option 3, I think we can eliminate option 2. It's not anybody's favorite. I think that everybody sort of sees 3 is better than 2 if you're going to go the route of raising the deductible. So, but could we have another option which is like 3, but it uses 15, 50, and 75? and see if we can
So-
lower the deductibles a little bit more.
Okay.
So
Okay.
so option one, Julie, which doesn't change the deductible and has the change for the primary care to 45. And the only difference, I think, from what Mark was just saying was the 20 instead of 15 for the generic. Does that not work? That one, is that why you guys went to option
That's the
2
one
and
we
option
want.
3?
Yeah, no, that's the halfway in between one we want. So it might, because you're doing 15, you'll have to raise the deductibles a little bit, but hopefully not as far as option 3 does.
Okay.
Yeah, so it'd be 15, 50, 75, $45 for the primary care. And what do the deductibles have to be to make it work? But I also, I mean, we still have option 1 on the table, and I actually heard some favorable sort of sense of that might be the best way to go, is to just raise the copays and the primary care copay more and leave the deductible where it is, and not, because that's the one that puts all the sort of pain on the small group of people that actually have the worst medical costs. You know, they'll just have to keep paying more and more. So fine to study all three and see just how that other option does. But all three are still, I mean, 1, 3, and the new one are still in play, I think.
Okay.
And to answer, I think it was Sean's had a question about why would anybody pick 2 over 3? Because the actuary value is a little bit lower, one would suspect that the premium associated with the plan, if it was option 2, would be a little lower than it would be for option 3. And, you know, everybody pays the premium. However, since the premium is subsidized so heavily by the federal government for a vast majority of our clients, maybe, you know, lowering the premium by a tiny little bit isn't such a important issue.
Yeah, thanks, Grant. That captured my thought process exactly. Thank you.
Yeah.
And I would like to point out, you know, as the silver AV range goes from 70 to 72. So since we're at the lower end of 70, so there is some room to push it up in actual value closer to 72. So making room with, you know, to do the things that you've suggested here. This was, you know, as I mentioned, the initial pass with the issuers to just make sure we can get some compliant plans to present to the group here and then start tweaking from there.
Great.
So Julie, do you think it's actually possible to just tweak option 1 and change the copay for generics from 20 down to 15, given the room slightly in the AV, without having to touch the MOOP?
There may be
there
may be the potential. I'll need to look at what my analysis does, and then obviously I will need to send it to each of the issuers to do their own testing.
Right, and I don't know if that something like that could change the outcome with parity.
Yeah, the mental health parity is also in play, right?
Okay, thank you.
So the next slide would be the 73% cost sharing reduction. And so any changes that we're proposing on the standard silver plan would need to follow through here on those copays, because the cost sharing needs to be either less than or equal to what is on the standard silver plan. So I think just based on the feedback I've received from the group, that, you know, I would tweak these as well based on the changes proposed to the standard plan with regards to the copays, especially on the drug side.
Great.
So if we go on to the next 87% plan on the next slide. As I noted, I did get feedback since this presentation was submitted to Access Health for today's meeting that we do need to make changes to the 87% plan. I had proposed to each of the plans issuers the alternates option 1 and 2. I did not hear back from all of the issuers, but the one issuer I did hear back from these two plans would pass the actuarial value testing as well as the parity testing. So there's still some feedback to gather. But, you know, this one, we were just looking at maybe tweaking the deductible a little bit and then taking the out-of-pocket maximum up to the regulatory maximum of $3,350 allowable. And then option 2 looks at, well, what if we slightly increase the primary care copay and then kept the deductible at a smaller increase. I don't know if there's any feedback from the individuals, if you'd like to see something a little bit slightly different with regards to these plans. And I
Does
think,
that mean, yeah, does anybody want to make an opinion about the two options that are, actually the first one, the current one, is that acceptable? I mean, it's 88.0. Is that within range, or is there a parity issue with that one? What?
Those are the 2025 results. If you look at the bottom
TBD,
row is
yeah,
a TBD.
Okay.
If I had completed it, I would have said it's out of range.
Oh, it's out. Okay, so now we know it's out of range. All right.
Yes. So we need to make a change. I've proposed option 1 and option 2, but since I'm going back to the all of the issuers on the silver, the gold and the silver option, you know, is there anything that you would like to see differently analyzed for the 87% CSR?
This is Mark Schaefer. I don't feel strongly about the two options, and I don't have a third option to recommend. If I had to vote now, I'd support option 1. Do you have a way to know whether the adjustment you're making will be sufficient, or you will have to determine that once you get the results back from the 2026 and you're just making an educated guess as to what will be needed?
Well, as I mentioned, I did get feedback from one issuer, so I'm hopeful, but that the other issuers that I have not heard back from may have a different result based on their own testing and data analysis.
Mm-hmm.
So when I get that back, I will go ahead and make adjustments and send out again for further testing. Either modifying the deductible as an option 1 or doing an option 2 and just tweaking the deductible as well.
Okay.
On the final cost sharing reduction plan, the 94%, similar to the 87%, we did get feedback from one issuer saying that the 2025 plan is out of compliance. So we do need to make changes for 2026. You can see option 1 and option 2, I followed a similar option, you know, 1 increasing the maximum out of pocket, option 2 also throwing in a copay change, so therefore keeping the out of pocket maximum lower. Because of the nature of the cost sharing, the deductible was not impacted, or there was no need to add a deductible for these plans.
Mm-hmm.
Once I get feedback from all the issuers, we can further decide if other options are needed, or if there's something you'd like to see as an alternate scenario for me to test before the next meeting. I'll turn it back to the group.
Yeah. I think we'll probably choose similar sort of make it similar choice on the 87 and the 94 plans. Either we'll raise the primary care, or we won't raise the primary care on both of them simultaneous. This one makes it very clear. I think you've got enough here. There's really just do one thing or do the other. Either raise the primary care or don't raise it. It's pretty clear. And so I think once we find out that it's acceptable for both plans, we'll be able to make a choice there.
Okay.
I mean, what are you going to do? $12.50 or something? $12.50 instead. There's not much you can do.
Yeah, the cost sharing is very low.
Yeah. Okay.
All right. Well, then let's go and look at the bronze non-HSA plan. So again, we took a similar, 3-option approach. This plan is out of compliance. All of the options have been received feedback from all the issuers about the parity testing. All comply, as well as the calculator testing. All of them comply. And so a similar approach where option 1, we didn't want to touch the deductible and maximum out of pocket. So we increased the primary care copay by $10 to $50. We had to also increase laboratory services from $20 to $30. However, it's still before deductible. And we did increase the generic and the preferred brand drug copays by $10 each. On option 2, it was a strict deductible maximum out-of-pocket limit change, while option 3, we tempered that deductible change with a primary care change going from $40 to $50. This would be an expanded bronze plan. So we do need to keep at least one service category before the deductible. And right now we have both the laboratory and the primary care, as well as, I guess, the generic copays.
Great. Okay.
And preferred brand. I apologize. I forgot we made that change last year. We can focus in on a certain option. I'm open because, as I mentioned, I'm going back to the issuers if there's an alternative option that you would like to see.
Does anybody have an opinion here? Either something they can throw away because it's not still in the running, or any tweak they want to make?
Since we consider the copays for primary care at 45, I think it makes sense to have the copays higher than the 45 for this option because it's leaner.
Yeah, so that would eliminate option 2, sort of. Option 3 is probably more aligned with the other plans. $50 copay for primary care. I think we keep 1 and 3 still. Does anybody want to tweak either one of those?
No, I support keeping 1 and 3.
Yeah. Well.
Okay.
Yep.
So then, based on that feedback, I'll adjust the presentation accordingly. The last plan design is the bronze HSA plan. All of the issuers indicated that this plan was still in compliance for both mental health parity testing as well as under the 2026 AV calculator. So based on that feedback, there was no need to necessitate a change in the current 2025 plan, pending any significant changes in the HSA regulations from the IRS. And due to the complexity of this plan, with regards to the statutory diabetic services coverage, we did not have the issuers do any alternate testing of the plans, tweaking the deductible or the out-of-pocket. So my recommendation is probably leave the plan as is, though I defer to the group if you would like to see alternate, HSA options.
No, I think we'll be happy to just keep it the way it is, but I will point out it will have to change next year. I think we've hit the maximum ceiling as far as ABC.
Mm-hmm.
0.97 is getting really close
Yes,
to
it's
the
very
edge.
close. So,
okay. Question, I think maybe do we want to vote on that, accepting that one today, or do we just want to vote on all of them in the future? Oh, Sean, do you have a question?
Just I don't think it's a question. I think it's just an observation of and probably not a fully formulated thought either. My guess is that people who are going to gravitate towards an HSA plan as opposed to a non-HSA plan might have some more resources to actually fund an HSA. And with that thought in mind, it's interesting that the HSA plan overall has lower overall deductibles and lower overall out-of-pocket maximums to meet the, where people, again, just an assumption that people who are going to choose this plan will actually have more resources and contribute to an HSA versus the other one. I don't know if that is actually a meaningful comment with respect to what we're being asked to do, but it was something that it just kind of struck me as I'm comparing these numbers.
Well, the HSA is covering their costs, and then obviously these deductibles and out-of-pockets are basically sealing, sort of like almost like catastrophic insurance or something. It's only like for the few people who reach those maximums does the insurance actually kick in at all. You're right, it's a different demographic, certainly. People with a little more money that are funding their HSAs, or it should be people that are funding their HSAs and using that money to pay for their normal medical costs. And this is really just covering extremely unexpected costs.
Yeah, the only thing that it can cover before the deductible is preventative.
Yeah, is that one? Yeah, okay. Is the
right, and that's why with the diabetes legislation, that's why we have this slightly funky list versus the other plans, because then there's that separate IRS guidance on what certain things could be considered preventative and certain things aren't. So those things to comply with the state diabetes caps to the extent permitted by this law. So that's how we arrive at that. But yeah, so to Grant's point, someone with this plan is paying for most of their care, certainly up to the deductible, other than preventative. Hopefully out of the HSA.
And to Susan, and also to Susan's point, I think that many of the other plans that we were looking at, a lot of the services are pre-deductible. And I'm not sure if that's something that we may need to focus in a little bit more on as we're going through these plans. But the changing a copay by $5, while it is a change, it is still pre-deductible. So as opposed to looking at the HSA plan where everything, they have to meet that deductible first. So
Yeah.
Something
Right,
else
and
to
that's
consider.
sorry, Cal, and that's been a big, as Grant and most of you know, that's been a big goal of ours with these standard plan designs, to the extent that we can, to make, you know, PCP and prescription drugs and lab and x-ray, to make things accessible to people, so to have as much as we can pre-deductible, so that it is accessible, even though the plan might have you know, high deductible, if you will, not for this plan, but in another plan, that many of those services are pre-deductible. So even though the plan has a higher deductible than this deductible here, they can still access all those services without worrying about the deductible.
Right. Okay. Great job. Thank you so much, Julie.
So we can vote if you got, if the committee did want to vote, we could vote on that one plan, or we can, you know, hold it for votes on the rest of the plans, whatever the committee wants.
Potential vote. Is anybody opposed to voting for that HSA plan now? It seems to be pretty established that that's what we're going to use. So we could take that one as sort of a preliminary, as a first, get that one off our plate, as it were, if you don't mind. Do I hear a motion to accept the HSA plan?
So moved. This is Sean.
Great, thank you. Second?
So moved. Mark.
Oh, okay. So any more discussion before the vote? If not, could we have a roll call vote on accepting the HSA plan, the bronze HSA plan?
Yes, Mr. Chair. Grant Ritter,
Yes, accept.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman,
Yes.
June Goen,
Yes.
Brendan Riff,
Yes.
and Manisha Sutani. Thank you.
Oh, motion carries. Thank you so much. We got something done today.
Mr. Chairman, before we move on, just one broad statement or comment. We are monitoring what's going on in DC and potential impact to everything that we're planning for 2026. One of the snags we had when our current president put a freeze on all federal spending, we reached out to our contacts at CMS to see whether or not this would have an impact on APTCs. They didn't know they were checking. Unfortunately, we got news recently that they have rescinded that order. So it's a little chaotic. Everything is up in the air. So we are monitoring very closely what's going on in DC and possible impact, not just to 2025, but also 2026. So if anything changes, again, all the decisions that have been made by CMS that's impacting our planning for 2026 could change based on how things are being managed at the HHS level. So we'll monitor that and keep you updated as we move forward. And as a matter of fact, we're going to send a note to the board later on today or tomorrow, making them aware of what we're doing and what we are watching out for and potential impact that may have. I just want to put that out there, it's just so that no one is surprised if we have to call another meeting because of what's going on in DC.
Okay, thank you, James.
Yes.
Is there anything else, follow-up that needs to be discussed, or is it? Our next meeting is on February 10th, as you can see, and we'll try to accept some more plans then. So we're going to do next steps. Kelly, is there next steps or is that pretty much taken care of?
I think that's pretty much taken care of. We'll meet at our next meeting, and then I think at that time, if we need to schedule another meeting after the February 10th, we can discuss at that time.
Okay, great. If that's the case, could I have a motion for adjournment?
So moved. It's Mark.
Thank you, Mark. Second?
Second, Sean.
Thanks. Roll call vote?
John Ritter,
Yes.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman,
Yes.
Tune Goen,
Yes.
Brendan Riff,
Yes.
and Manish Jutani. Thank you.
Thanks, everyone.
All right.
And we are adjourned.
Bye-bye.
Thank you, everyone. Bye-bye.
Thank
Take
you,
care.
everybody.
Good to see y'all.
Bye now.
Bye.